intrinsic, extrinsic, you guys know this already. You know, which one is PTT, which one is PT, which one is common pathway. The PT is warfarin, the PTT is your heparin. Okay, and INR, you can use that for for your warfarin also. Okay. This is what I was talking about earlier, your prothrombin complex concentrate. This could be used to reverse warfarin. Okay. So where does D-dimer comes from? D-dimer, where does it come from? So think about it. So you have prothrombin, thrombin, that's your clot, okay? Then if you wanted to destroy, if you want to just stop the clotting, then what you're going to do, um, uh, you are going to produce, plasmin, and that plasmin is going to break the fibrin. The fibrin clot is going to break that. And once it breaks that fibrin, so you have to remember, when you have fibrinogen to fibrin, it's still not stable, called fibrin monomers. These are fibrin monomers. When you add factor 13 will convert your fibrin to fibrin, stable fibrin, okay? And that's when you have fibrin polymers. Now, when you now break down fibrin polymers, you're going to get D-dimers. So D-dimers come from fibrin polymers, whereby your fibrin monomers will give you fibrin degradation products. Call it fibrin degradation products. So D-dimer come from the stable fibrin or called fibrin polymers. Mention at least 5 diseases with increased D dimers. Anyone? Well, just remember I am clotted. I am clotted thrombosis. That will give it away. What is the drug of choice for DVT? Low molecular weight heparin, right? Okay. The next one to talk about is your DOACs. Your DOACs, are your direct oral anticoagulants. There are different types, right? You have your factor 10A inhibitors. It's called apixaban. And you have your thrombin inhibitors, your dabigatran, your agatroban. The main thing you have to know here is when it comes to factor 10A inhibitors, what you're looking for is band XA. So from the name, anytime you see band XA, band XA, band XA, so their function is to band factor A. So this is give an example of factor 10A inhibitors. What you're looking for is band 10X, band 10A, band 10A. So that will give it that. Then you also have thrombin inhibitors. They call it direct thrombin inhibitors. That's your dabigatran or your agatroban. Okay, so if you look right here, your factor 10A. Okay, what stops factor 10A are your band FA. Those, the example that I just gave you. But when it comes to your thrombin, what can I use to stop the thrombin? Those are your direct thrombin inhibitors, your dabigatran or agatroban. So when you have a patient, right, that is a high risk, okay, for bleeding, okay, you don't want to give them any anticoagulant. Then what you want to do is to give them that, pneumatic compression socks, okay, especially when they have a high risk of bleeding. All right. Now, don't forget with DOACs, you want to make sure you order some creatinine clearance on them, check their kidney to really make sure their creatinine clearance is between 30 to 50. Anything below 30, you can't give DOACs because it was with the kidney. Okay. Let me stop here. Any questions?
Yeah, actually, what were you saying about the compression socks?
So when you have a patient that is a high risk for bleeding, they have a very high risk of bleeding. So basically, you don't want to give them any anticoagulants. You want to give them a pneumatic compression stockings or compression, boot,
Okay.
and that will prevent DVT. All right. So if they say, this patient has got a cranial bleed, right? A patient with cranial bleed, you want to give them anticoagulant? Absolutely not. So the next you have to give them is to give them pneumatic compression boot or compression socks.
Thank you.
Okay. So again, if I ask you, is this a direct thrombin inhibitors? This one right here, this one, this one, this one. What do you think?
Yes.
No.
Nope. Why is it no? Why is it no?
That it inhibits factor 10A.
Right. It says Ben 10A. It's right in the name. When you see Ben XA, Ben 10A, Ben 10A, that is your 10A inhibitors, right? But when it comes to your dabigatran, your agatroban, since they don't have Ben 10A, that is called your direct thrombin inhibitor. All right, we're good?
Yes.
Okay. Okay, this is what I was talking about. So if you blocks 10A, you're gonna say ban 10A. It's simple. Does that make sense? Am I repeating myself? Makes sense, right?
Yeah, that's a good
Yeah.
mnemonic.
Yeah.
And this one, thrombin, direct thrombin, if it's not ban 10A, then it's automatically direct thrombin. Okay? All right. Okay. When it comes to warfarin, so this is a very highly, every single year, I don't know why. They ask this question on the board. I don't get why. So, real quick. So when you have a patient on warfarin, you are checking the INR. So if they have surgery, you want to stop the warfarin 5 days prior to the surgery. Okay, 5 days prior to the surgery. Now, when do you have to bridge? Okay, when do you have to do, a bridging for warfarin? If it's a low risk, meaning that I'm doing a paronychia, I'm not going to stop a patient on warfarin. Just paronychia. I'm just going to just take it out and put pressure on, let it start the bleeding. Okay, if it's a moderate risk or high risk patient, those two people I want to consider stopping heparin, warfarin. So if you want to stop warfarin and you want to bridge it with heparin, what you have to do is to stop the warfarin 5 days prior to surgery, right? And once you stop it 5 days prior to surgery, 3 days later, you're going to start low molecular weight heparin. 3 days later, remember that. 3 days later, you're going to start heparin. Okay. And once you start heparin, you're going to discontinue heparin 24 hours before the procedure. Okay. And after the procedure, you're going to restart the heparin 24 hours later. And also, you're going to start the heparin 24 hours later. Does that make sense?
Can you repeat that one more time, please?
If I have a medium risk or high risk surgery, okay, and my patient is on warfarin, I want to stop the warfarin 5 days prior to surgery. The reason why is because it takes a long time for the INR to reduce to go back to normal. So I've stopped it 5 days before surgery. Once I stop the heparin, you have to remember the heparin takes a long time. Sorry, the warfarin takes a long time for it to go back to normal, especially when you're monitoring the INR. So the first 2 days, they still therapeutic. Okay. After that second day, which is your third day, at your third day, 3 days later, you want to start heparin. But heparin is a short acting. You want to start heparin and continue them on heparin until 24 hours before surgery. That's when you're going to stop it. And after surgery is over, you're going to start two things. You're going to start the heparin again, and you're going to start the warfarin together. Once the warfarin is therapeutic, then you're going to stop the heparin.
Are you starting them both 24 hours after the surgery?
That's right.
Okay. Thank you.
When the warfarin is therapeutic, meaning that when the INR is above 2 or 3, then I will stop my heparin and send the patient home on warfarin.
Okay.
Okay. So a lot of information. Okay. Oh, this is huge. DIC. What is DIC? Disseminated, meaning affects the entire body. Intravascular, within the vessel, coagulation, thrombosis. So that means you have thrombosis all over your body within the vessel. That's what I mean. DIC, disseminated intravascular coagulation. The number one cause of this problem is gram-negative sepsis. All sepsis could cause it, but your number one is your gram-negative. Your number two is cancer. Your number two is snake bites. Okay. And I'll stop that. Just your first three. Okay. So what exactly is going on here? So basically, with disseminated intravascular coagulation, what you have is you are making too much clotting factors. So something is making you to make too much clotting factors and cause it to develop severe DVT, right? So guess what's going to happen? Just like your myelofibrosis, when you use too much of your clotting factor, right? It's going to get to a point they're going to be gone. There's going to be nothing left. Okay, when it's nothing left, literally from clotting too much, then they're going to start bleeding too much. So that's why the disease is so deadly. Okay, so the first thing that happens is they're going to clot too much. Then later on, they're going to bleed too much. Okay, the reason why, because of the clotting factor is gone. So that's why in DIC, what you see is that you're going to have low clotting, all clotting factors are going to be low. Okay, you mentioned everything is low, even platelet is low, everything is low. Okay, the only thing that's going to be high is your bleeding time. Why is your bleeding time high? Because your platelets is low. Your PT is going to be high. Why is your PT high? Because your clotting factor is low. Why is your PTT high? Because your clotting factor is low. Why is your bleeding time high? Because your platelet is low. So all the clotting factor is all low. So that's how you diagnose this. So when you look at DIC, basically your platelet count low. Okay. What else? Platelet count is low. Clotting factor is low. Um, um, the only thing that's gonna be high is gonna be a lot of class stuff, which is D dimer is gonna be high. FDP is gonna be high, which is fibrin to get a product is gonna be high. You know, what about your fibrinogen? Which your fibrinogen will be high or below in DIC?
Low.
Got it. Good job. Excellent. How do you treat DIC? Whatever that's causing a problem. Okay. If they are bleeding too much, give them FFP. If they are lacking factor A or fibrinogen, you give them cryoprecipitate. If they are low on platelet, you give them some whatever they need. You just give it to them. Okay. Now, when it comes to COVID could lead to DIC. What's the number one problem with COVID? Say blood clot. Anytime you say COVID, say blood clot. Anytime you say COVID, say blood clot. What is the best way to treat blood clot? Anyone?
Anticoagulants.
And which one?
Low molecular weight heparin.
Oh, molecular weight heparin. Can you tell me two diseases that you have to use Coumadin? Two of those.
You asked what are two diseases that you have to use Coumadin?
Yes.
Mechanical valve.
Uh-huh. What else?
I was gonna say mechanical valve. I'm blanking on the second
It's
one.
the antiphospholipid.
That's right. That's right.
syndrome.
That's right. Antiphospholipid syndrome. That's right. Which is very common in pregnant people. So when we have a pregnant woman, is always losing babies, always having spontaneous abortion. that is your antiphospholipid syndrome. And those two, better put them on Coumadin. Okay. Anyway, COVID, think of blood clot. And best treatment, think of medical heparin. Okay, let me keep rushing. We talked about this already. This is a lot of information. My God. Okay, this is very important. I know some of you guys are struggling when it comes to cancers. I'm almost done. Some of you guys are struggling with cancers. So basically, if you have a pen or paper, can you write this down, please? Get a pen and paper. Or if you want to do it, on your computer is fine, or you do it on your iPad and write it in there. Okay, so let's do this together. Okay. I want you to write ALL. Starting from the left, write ALL. This is when you're writing ALL because A starts without before C. So let's write ALL. You got it? Did that already?
Yep.
Okay. Then on the far right, on the far right, you're gonna write CLL. So you have ALL. Then on the far right, you have CLL. Got it?
Yes.
Perfect. The next one is we're gonna come back to this middle here. Since you start with ALL, acute lymphoblastic leukemia, okay, now we're gonna go to myelogenous leukemia. So we are gonna start with C. So instead of starting with A on the middle here, you're gonna start with C and reverse it. So you're gonna say CML, then you're gonna go to AML. Does that make sense? Okay. Now the reason why we're doing that, I tell you, ALL is seen in 10-year-old, less than 10-year-old. CML, less than 40-year-old. AML, less than 50-year-old. And CLL is seen in 80-year-old. Does that make sense?
Yep.
We're good? So basically, the first thing you have to look for is um, if they're telling you a patient is having a massive production of lymphocytes, okay, and their age is 10, okay, and they have anemia, okay, and they ask you what kind of leukemia is this, and you know your answer is going to be ALL, right? Okay, they say a patient is producing too much neutrophil, and they have anemia, okay, and their age is 40 or maybe 38. They have, Philadelphia chromosome 922. Okay, what's your diagnosis? CML. Or patient is producing too much neutrophil, so you know you're talking about AML, but that's myelogenous leukemia. And they have RODS, that's AML. Okay, a patient is, elderly, or the I'm sorry. I'm so sorry, guys. So does that make sense what I'm trying to say? So on the
Yeah.
exam, look for, are you producing, lymphocyte? Remember lymphocyte from lymphoid lineage, right? If it's lymphocyte, you know you're dealing with ALL or CLL. Then look at the age. If the age is less than 10, you know you're doing ALL. If the age is, elderly, like 60 something, you know you're dealing with the ALL, a CLL. Okay. Now, the when it comes to CML and AML, look for the Philadelphia chromosome 922. Look for something that will help you out. If they say too much neutrophil, you know it's coming from your myeloid, stem cell. Okay. The question is it CML or is it AML? They'll give you clues. They're gonna say patient is 50, 40. That's kind of, it's kind of close there. What you want to do is, just look for a Philadelphia chromosome and that will give it away. Or if you see our rod, that will give it away. Okay. Um, okay. So then the next thing is um, there's a mnemonic that I have that I use all the time. You know, so there's a mnemonic that I use all the time. It's called PMN, paramononuclear, cells. So PMN, okay, Philadelphia chromosome, basically you have the myeloperoxidase and you have nothing, when it comes to the test we use to, diagnose this. And with this one, you have the positive TDT, okay? And how do you treat it? And it's right there. But the main thing you have to remember, really, and how to take care of this, is just do exactly what I told you. Start on the left side, go to the far right, CML in the middle, and to follow AML. And you go from there. That'll kind of give you the age. All right. Now, another thing I want to bring up is when it comes to CML, okay, the best treatment for CML is called tyrosine kinase, also called imatinib. So that's the best treatment for it. You have to know that. Well, that's the treatment of choice. So when you have BRABL, what does that mean? What do you see that? Do you guys remember that? I think that was discussed.
Is that CML related?
Anything else?
There were,
Is the Philadelphia chromosome?
Okay. Can you also see somewhere else?
is it breast cancer?
Mm-mm. What do you see in breast cancer, by the way? Which one do you see in breast cancer?
BRCA.
What is it?
BRCA.
BRCA1 or BRCA2. So basically, my wife is calling me, getting upset at me, texting me. So yeah, BCRABL is pretty much what you see in your Philadelphia chromosome, T90, T922. So that's where you see that, but when it comes to BCRA1 and 2, you're going to see that in breast cancer. Okay, so that's what you have to know about this. Now, another thing you have to know about this is that this ALL responds very well to treatment. Okay, when it comes to CLL, is the less aggressive. Okay, and these two right here, they have a very worse prognosis. These two in the middle. So your neutrophilic leukemias, they have that worse prognosis. These two right here.
Wait, so what was the other thing it was affiliated with?
Which
The
one?
BCR ABL.
That's it. Chromosome. I'm not gonna confuse you. I don't think this was discussed, so let me just stick with that. So that's your chromosome, parental chromosome,
Okay.
BCRABL. Okay, we're good.
Yeah.
Yep.
All right, so that's it. So basically, real quick, Hodgkin's lymphoma. I'm gonna rush now. What you're gonna see is your Reed Stamberg study. You guys know what that is already. I think there's a picture on. I don't know where it's located, but I'll get to that. There's a picture on it. Anyway, Reed Sternberg styles, you're going to see that. Which one is more common? non-Hodgkin's or Hodgkin's lymphoma? Which one is more common?
Isn't it non-Hodgkin?
Non-Hodgkin's, that's right. So you have to know this. I think there's like one or two questions on this in exam. You have to know this, very important. So basically, when you have they call it the N-Haber staging for Hodgkin's lymphoma, and exactly what is that? So basically, when it comes to the system, it talks about locate the lymph node group. So what are the lymph node group? So you have the cervical lymph node, that's a group. So listen to this. You could have 15 of those. Again, as long as it belongs to the cervical or the neck, that's one. Okay. If it affects the axillary, that's two. If it affects the groin or inguinal lymph node, that's three. Okay. So that's where it works. So one lymph node group is one. If it affects two or more, okay, that's state two. Uh, on either side, that's state two. State three, if it involves the node on both sides of the diaphragm, that's three. And if it's all over the body, that's four. Okay, let me repeat. One is one lymph node. Two is when you have two or more on the same side. So let me just give an example. So if I have this lymph node that's affected on the neck, cervical lymph node, that's the only thing that's affected. That's stage one. If it's a groin that's affected, that's stage one. It's only the armpit that's affected. That's stage one. Okay. If it affects both, the lymph nodes, in the armpits and also the neck, that's two groups. That's stage two. Okay, because on the same side. But if you have one, okay, on top of the diaphragm is right here, one on top of the diaphragm and one below the diaphragm, that's stage three. Okay, and stage four is all over the body. Does that make sense?
Yes.
Okay. So one is just one. Two is going to be on the same side of the diaphragm. So if it's above the diaphragm, it's fine. If it's below the diaphragm, it doesn't matter. It just got to be on the same side. Okay. Then you have two or more. When you involve either both side on top of the diaphragm, below the diaphragm, that's three, and over the body is four. Then the next you have to look for is modifier, modifier A, meaning that there are no symptoms. What are the symptoms they're talking about? Fever, night sweats, and weight loss. So once you out, they're telling you a patient has a positive Reed-Sternberg cells. So you're talking about actin lymphoma, and they say they have lymph node, they have cervical lymph node that is positive. They have inguinal lymph node that's positive. They have fever, night sweats, and whatnot. What do you think that is? What's your staging?
3B.
That's right. That's 3B. Exactly. That's 3B. So just know this, okay? Just know that's how they do it. Okay. Just know that, okay? Okay. So look right here. Is this stage one or stage two?
One,
Stage one or
Two.
stage two? Two.
2.
two,
So this is
3.
occurring on different sides. So that diaphragm on top and bottom, right? And this one right here is all over, okay, affecting everywhere. So if you have a fever, that's B. If there's no fever, that's A. Just like that, multiple myeloma. The main thing you have to remember here on multiple myeloma, you guys remember multiple myeloma comes from the lymphoid stem cell, and it comes from B cells, and that will give you your plasma cell. That's your multiple myeloma plasma cells. When these plasma cells are defective, okay, you guys remember plasma cells they are really important to produce antibodies. So when they are defective, and you have too much production of a defective plasma cell, that's called multiple myeloma. So with multiple myeloma, what's really affected is your IgG most of the time, and your IgA and IgD. People will say mostly the IgG. And one of the things that you see with multiple myeloma is that you're going to see increased production of branchial. So there's going to be destruction of bone because the body wants to produce more calcium. That's why in patients with multiple myeloma, you see increased calcium. Okay. So another thing you see you have excessive production of light chains in your immunoglobulin. So your immunoglobulin, they have the heavy chain and the light chain. So this is your light chain here. What happens is that you have excessive production of light chains, and those light chains will end up in the kidney, and that will cause renal failure. And that's the reason why most people in multiple myeloma they develop renal failure because of too much production of light chains. And when those light chains get into the kidney and into the urine, they are called Burns-Jones proteins. Okay. Now, another thing you see, remember I told you already that electrophoresis could be used for sickle cell, could be used for thalassemia, could be used for multiple myeloma. So with multiple myeloma, basically what you're going to see, this is normal. Albumin is the only one that you're going to see a spike, right? But in your multiple myeloma, what you're going to see a gamma spike. Okay, they call it monoclonal spike or M spike. So you're going to see that spike, they call it M spike, monoclonal spike. Monoclonal spike just means that you're not supposed to have any spike except for the albumin. If you have any other spike, they call it monoclonal, meaning that there's one, there's one globulin that's spiking. And most of the time you see that, with your multiple myeloma. So there's a mnemonic called CRAB. Okay, so make sure you remember this. CRAB is the way you diagnose multiple myeloma. C is eye calcium. Remember, they have bronchial, their bone is being broken down, they produce so much calcium. So you have eye calcium. The next one is R, renal disease. Why renal disease? The Benz-Jones, right? The light chain that's ending up in the kidney. The next one is A, anemia. This is when they have anemia. You have to remember they are producing too much B cells, and those B cells is really causing problem in the system in the body. Instead of producing enough, RBCs, now you have so much of this plasma cell all over the body that is occupying where RBCs should be occupying. So you're going to develop anemia. The next one, you're gonna get bone problem, bone pain. Why? Because you're breaking your bone to produce calcium. So they call it crab. Now, because of all this that is happening, these people are very prone to infection. So, crab, just talked about that. In multiple myeloma, in the smear, you're gonna see your stacked on RBC, a stacked coin RBC called a rouleau formation. You're gonna see that. Okay. And the best way to treat that is a cancer, you do chemotherapy and radiation. Okay, this is a sample of an exam question I'm going to give you. You have a patient that's 60, 65, they have pain in the back, bone pain right there. Okay. The next one is they have anemia right there. Anemia is right there. They have rouleau formation. Once you see that rouleau formation, don't waste your time. Your answer is multiple myeloma. Just look for clues. Look at this one. Calcium is elevated. Boom, you'll see and your R. Let's see what's going on with the kidney. This is about kidney. Look for kidney here. See kidney here? I don't see kidney.
I
Proteinuria?
mean, there's proteinuria.
What is that? I don't see it. There you go. There you go. Yeah, proteinuria. Right there. Right there. There you go. That's kidney. So there you go. That's right. That's your crab right there. So that's what you look for. Once that rouleau formation, that's just the dead giveaway. Okay, almost done. Almost done. So basically, what is the number one common cause of what's the most common cancer in the entire universe?
Lung.
Lung, exactly. You can see in men, the highest mortality, lung. Women, the highest mortality is lung. So in men, basically the first thing you see is lung. The second one you're going to see prostate that will kill men. And the last one is colon. So go down the line like that: lung, prostate, and colon. In women, the first thing that's going to kill them is the lungs. But the most common in female actually is breast, followed by colon, followed by lungs. But which one's going to kill them first is the lungs. Okay. So it's kind of confused. So be careful with that on the exam. The most common cancer in women is breast, followed by colon, followed by lung. The most common cancer in men is lung, followed by prostate, followed by colon. But they ask you which one has the highest mortality. Okay, it's your lung first in both. Breast cancer in female, which is second. prostate is second in men, and colon is the last for both. And don't forget, when it comes to HPV, cervical cancer, you want to do the HPV vaccine. Smoking, kill you. Smoking is the number one cause of cancer. Which one is the most common cancer of the lung? Which type?
Endocarcinoma?
Give it. Well, I know that's true. Give me another one underneath there.
Small cell.
So did you say adenocarcinoma? Is that what you said? I didn't hear you.
Yeah.
Okay, so I'm sorry, I didn't hear. So adenocarcinoma, that's right, adenocarcinoma. That's the number one. Okay, when it comes to colon cancer, basically you want to start screening, pretty much at the age of 45. If you have a history of it, you want to start screening sooner. Okay, the best way to diagnose colon cancer is the colonoscopy. Okay, and the clues you're looking for, a patient will tell you, I'm having GI bleed, I'm losing weight, I'm having constipation. So just know you're worried about colon cancer. Okay, prostate. Be careful with prostate cancers, right? With prostate cancer, if you have a patient that is just saying, we have a prostate cancer in our family and I'm just worried and they're very healthy, there's no problem with them, you should never order PCA. The only time you order PCA is if you want to monitor a patient that's been diagnosed with prostate cancer. That's when you're going to order PCA to monitor them. Or if the patient is above 60, 70, if you want to do PCA, that's fine. But someone that's young, you don't want to do PCA. The first you want to do is to just do digital rectal exam. Put the finger into their place and just check the mass and make sure there's no, irregularity. That's the best way for people that are younger. And just encourage them, give them education, talk to them, and encourage them, and you know, but never order PCA on a patient that is young and healthy, that is just concerned for cancer. Okay.
So would you say that the gold standard is a rectal exam for prostate cancer?
Right. So basically, the first thing you have to do is to do a digital rectal exam on a patient that is symptomatic. A patient that's got a BPH. You want to feel it. Feel it first. Once you feel it, and you think, oh, wait a minute, this is pretty big. It's irregular. At that time, you want to order some advanced imaging studies. Get some advanced imaging studies, PET scan on them, ultrasound, CT scan, what they want to do on them. It's kind of see what's going on, with that. And once you diagnose that cancer, at that juncture, you want to get your PCA, PCA on them. And the function of that PCA to really matter your treatment. Okay. Now, when you have someone, that is elderly, yes, in elderly, can you order PCA? Yes. First, you do first though, you always you just like when you have a patient that's got a poor circulation, you do ABI first, always, right? So same thing here. Always do digital rectal exam first. That's your first line treatment. Then people that do elderly, like 60 something to 70 something, above 70, yeah, you can do PCA on them. Why not? But people that are younger, you want to stay away from doing PCA. But they've been diagnosed with cancer already, prostate cancer already. Yes, order PCA. Does that make sense?
Yeah.
Okay. So when you have a patient that's got unintentional weight loss, think of cancer, right? You want to order X-ray, order CT, and especially when you have a patient that's got a positive mass in their breast, right? You want to do a biopsy. Biopsy is the main goal here, and also check their lymph nodes, right? So mammogram, you want to do mammogram, starting at age of 40 and above, and do it every 2 years. People with possible cervical cancer, you want to give them a vaccination for that. Okay. You get lung cancer, your number one cause is smoking. And the number one type of cancer is adenocarcinoma, okay. So when it comes to your staging, T and M, you have to know that? Absolutely not. It's way too above our pay grade. We don't have to know that. Now, this condition you have to know, tumor lysis syndrome. What is tumor lysis syndrome? Tumor lysis syndrome is pretty much when you have a patient that's been diagnosed with cancer and you place them on chemotherapy. Sometimes the chemotherapy would destroy the cancer cells. And when they destroy the cancer cells, Some of the cancer cells will now, cause increase in calcium, increase in phosphate, and increase in potassium. There's a question like that, on your supplemental medicine that talked about this. I'll say you should review that very well. So my antibiotic that I use is called PPC. So patients that have tumor lysis syndrome, they have estrogen cancer, they're on chemotherapy or radiation, and now they have increased calcium, phosphate, and potassium. So just know that tumor lysis syndrome.
What about uric acid?
Ooh, who said that?
John Kashani.
God bless you. I forgot about that. Jesus Christ, I forget that. So my mnemonic is gonna change. You're gonna mess with my mnemonic. I like that though. Thanks for doing that. Let's what should we call this mnemonic now? I don't know. Whatever. Well, yeah, I don't know.
How about CUPP?
Let's do CUPP. Whatever. Yeah. Cup. Yeah. Yeah. CU cup. Yeah, I like that. Thank you. Well, listen. Let me tell you something. This is the reason we do this review, right? So we could just study together. You ask me a question, I ask you a question, I correct you, you correct me. We go together. It's like a studying session. It's not for me to teach you again, just studying session. Thank you. Uric acid is huge, very huge. Okay, thank you so much. So you're going to see increased calcium, phosphate, potassium, and uric acid. Thank you so much. Okay, colonoscopy, we talked about that already. AML, seen in adults, poor prognosis, and you see our rods. What else do you see here? What chemical do you see that'll make it positive? Anybody know? I'm gonna show you again. I'll show you again. With AML, myeloperoxidase is very important. That's how you test it. Okay, they have positive myeloperoxidase. Okay, myeloperoxidase. Okay, just FYI. Okay, myeloperoxidase. ALL, remember ALS in children less than 10. They have great prognosis. Great. Okay. All right. What is this? Acute leukemia. Don't worry about that. Again, CLL is common in older people. And the prognosis is also pretty good. If you notice, your lymphoid, stem cell, leukemias, they have a really good prognosis, but your CML and AML, forget it. Okay. So this is what I was talking about, when you have the staging, we talked about that already. Okay, you gotta do biopsy. Okay, take a picture of this, make sure you know this very well. Okay, the differences between Atkins lymphoma and non-Atkins lymphoma. Non-Atkins lymphoma is very common. Okay, basically you're gonna see Reed-Sternberg cell in Atkins. Okay. Another thing that's very important here is that this is contagious, a contagious spread. So three things to remember here with Atkins. Basically, you don't have, extranodal involvement with Atkins. That's number one. You're going to see Reed-Sternberg. That's number two. It's contagious. That's number three. Number four is a treatment. There's the treatment, chemotherapy treatment drugs called the ABVD. Okay, that's how you treat this. With non-Atkins, it's extranodal. Okay, bad prognosis, not contagious. Now, with this, the best treatment is called CHOP, CHOP. Again, this is our medication for this disease. So make sure you take a picture of this, remember this, go over it again, okay?
What was the ABVD again?
They are chemotherapy drugs.
Okay.
Yeah. No, don't ask me, what it stands for. I'm not a hematologist or oncologist. So
No,
uh,
I thought you might have mentioned it and I thought I missed it. So as
no,
long as I generally know, yeah.
I didn't mention it at all. I don't want to say winter Christine, something like that, so whatever.
Oh yeah, those ones.
Yeah, exactly. So there's something called the starry night appearance. You see that in bucket lymphoma. Okay. Just know that. Again, PSA, for prostate cancer, yes, you want to order it. For a patient that's asymptomatic, meaning that they don't have BPA, they have no burning in the urine, they have nothing, nothing, nothing. You do not do PCA. Just give them a little, you could do, if you want to do a rectal examination on them, you could do it. But on these people, the best thing, okay, is to just educate them and say, you know what, you're doing fine. Don't worry about it. You're not peeing with burning sensation. You have no symptoms really, you're fine. Just educate them. What's worse, you could say, okay, let me do a rectal exam. The rectal exam is negative, you don't do nothing else. That's it. Patient that's been diagnosed with prostate cancer, yeah, you do, PSA and DRE on them. Again, let me read it to you. Do not, order in patient with unremarkable medical history with normal physical examination, do not order PSA, right? We discussed that already. Mammogram, discussed it already. What's the best treatment for ITP? Steroid. If the steroid is not working, what else can you give? Anyone? If the steroid is not working, what else can you give? Immunoglobulin. Yes? Agree?
Yeah.
Agreed.
Why do you have to give agatroban on a patient with heparin-induced thrombocytopenia?
It's a direct thrombin inhibitor.
Why do you have to give it?
To stop the clotting.
That's right. That's right. To stop the clotting, prevent clotting, agatroban. Okay. Um, what if I say apixaban? Okay. Is that a direct thrombin inhibitor or factor 10X inhibitor?
10.
Factor 10.
Factor 10.
That's right. DIC. What's the problem with DIC? Talk to me.
Clotting.
And what else?
And
And
bleeding.
That's right. What happened to all the clotting factors?
They used up.
All your stuff, they're low. They're low. Okay. Multiple myeloma. Okay. Why do you think they get crabs? Talk to me. What's crab?
renal issues.
Uh-huh.
Bone issues.
Start with the C for what's C?
Hypercalcemia.
Uh-huh.
Anemia,
Uh-huh.
bone issues.
Are you guys seeing my slide?
Mhm.
Yeah, okay. It's right there. IgG, IgA, M spike, okay, especially your gamma spike, Benz Jones, the light chains. Okay. All right. The number one cause of lung cancer is
Okay.
Smoking.
the number one common type of lung cancer is.
Adenocarcinoma.
I am done. That's a tough one. Guys, go to bed. It was a tough one. I hope this session really helped. Do you guys have any questions for me?
It was helpful. Thank you.
Thank you so much. Really appreciate it.
you.
Drive home safe.
Thank you.
Thank you. I'm gonna tell Adriana to post this tomorrow so you guys can look. Do me a favor, please don't share this. As you can see, some of these slides are not mine. I want to get in trouble, please.
I promise we won't.
No one's gonna share anything.
All right, thank you. Take care, guys.
You as well. Bye-bye.
Thank
Thank you.
Thank you.